Welcome to Topic 6, Part 1, Respiratory Disorders. We're going to start by a review of some normal respiratory physiology principles. So here are our learning objectives. So respiration can be divided into three parts. Ventilation, this is simply just moving air in and out of the lungs to the gas exchange surface. Perfusion, when we're talking about respiratory physiology, we're talking about pulmonary perfusion. So perfusion of the pulmonary capillaries with blood. Diffusion, the movement of oxygen and carbon dioxide down their partial pressure gradients from high to low between the pulmonary blood and the alveoli. So whether we have adequate oxygenation and removal of CO2 is going to depend on those above factors, as well as matching of that ventilation to that perfusion. So let's start with ventilation. So ventilation, as I mentioned, is just movement of air in and out of the lungs to the gas exchange surface. Now, how well we are ventilating is going to be affected by pulmonary compliance, surface tension, and airway resistance. So compliance is equal to the change in volume with a given change in pressure. In other words, it's a measure of how easily the lungs can be inflated. If we have a really compliant lung, that lung is going to inflate very easily, like an overstretched balloon. So picture taking a balloon. I used to do this for my kids all the time. And you blow it up and you let it go. And you blow it up and you let it go. And you blow it up and you let it go. And the kids chase the balloon all over. But what happens to the balloon after you've blown it up many times? It gets kind of overstretched. So picture that over time, that balloon will be really easy to inflate, but it's not going to go completely back to its original size. Okay? In the case of a overly compliant lung, it's not going to go back to its original size. In other words, we're going to have some air trapping because we've lost some elastic fibers. And we'll see that that occurs with emphysema. A non-compliant lung, on the other hand, is going to be really hard to inflate. Think of a stiff balloon. You remember those long, skinny balloons that people making animals or swords or hats or whatever out of them would use those balloons, and they were really difficult to blow up. Many people would use a pump to blow those up. Too hard to blow up on your own. Anyway, in those balloons, they're really difficult to inflate, but air can easily leave when you deflate it. Okay, so this is like a non-compliant lung. These patients are going to have a really hard time getting air in, but air can leave easily. And this could happen like with pulmonary fibrosis. Now, compliance is also going to depend on the elastin and collagen fibers. Like I mentioned with the overly compliant lung, we've lost elastin fibers. Or if we have too many collagen fibers, that can make a non-compliant lung. It's also going to be dependent on water content and surface tension. Let's take a look at surface tension. So surface tension at the air-liquid interface is an important factor in lung compliance. So the forces that hold those liquid molecules, those water molecules together, are stronger than those that hold air molecules together. So think if I were to drop a little water on the surface of my desk, it would bead up. Okay, because the attraction for water to water is stronger. So if we think of this in terms of the lungs, there is a liquid film covering the alveoli, and this would tend to want to cause the water to bead up, and that's going to make inflation of the alveoli difficult. So this increased surface tension would result in a decreased compliance and a much greater difficulty expanding the lungs. Now surfactant is something that we have to overcome that. And surfactant is made by alveolar type 2 cells. And this is a detergent-like substance that reduces the attraction of water for water. And it helps spread that film out evenly along the alveoli, and this is going to dramatically decrease the surface tension and prevent the collapse of alveoli. And it allows small and larger alveoli to coexist together. Okay, so this surfactant film is actually going to be thicker in the small alveolus to help overcome more surface tension, and thinner in the large alveoli. So this small alveoli doesn't just simply collapse in the air, transferred into the larger alveoli. Okay, airways resistance. This is another factor. And this is how much resistance is there to air getting into and out of the lungs. Now, normally airway resistance is really small, but even little small changes in the radius of airways can lead to large changes in airway resistance. So let's talk about some of the things that can affect the resistance, airway resistance. Lung volume. So airway resistance is affected by lung volume being less during inspiration, and this is kind of shown here with a higher lung volume, and greater during expiration with a lower lung volume. And the reason being is with inspiration, the airways are kind of stretched and pulled open, so that increases the diameter. And then with lower lung volumes, with expiration, those airways kind of collapse, and that's going to reduce the diameter. There are various neural and local control factors that affect the smooth muscle of the bronchioles. And if those smooth muscle cells contract, then we get bronchoconstriction. If they dilate, or relax, I should say, then we get bronchodilation. And we'll talk about those factors in a minute. And then whether the airflow is laminar or streamlined, and where the velocity is low, that's going to make for less airway resistance. And where the airflow is turbulent, and this occurs in some places where the radius is large, but the velocity of flow is high, and this makes more resistance. Overall, the greatest resistance is found in the medium-sized bronchi, and this is where the diameter has started to decrease significantly, but the airflow is still turbulent, and there's not so many parallel channels. Okay, so let's look at the factors that affect that airways resistance. So factors that are going to decrease resistance or open up those airways. So sympathetic stimulation is going to cause bronchodilation, okay, as does epinephrine. High lung volumes, as we talked about, the tissue forces stretch and pull the airways open, and that lowers the resistance. Some factors that increase the resistance, parasympathetic stimulation. Things such as leukotrienes and histamines. Remember we talked about in topic 3 about histamine causes bronchoconstriction, and leukotrienes cause bronchoconstriction. Inhaled irritants. If you breathe in toxic chemicals. I remember when I was a teenager and I was a lifeguard and I was adding hydrochloric acid to a pool, and I breathed in some of those fumes and I got a bronchoconstriction. It's kind of like a protective mechanism in that case. Inflammation and mucus, so the edema in the airways is going to, of course, narrow the airways. Mucus, extra mucus in the airways is going to significantly block airflow. Low lung volumes, so we get collapsing of the airways, less tension on the airways, and that's going to lead to increased resistance. And forced expiration, and that kind of goes hand in hand with low lung volumes, but because it is force that does that even more so than a slow expiration. Okay, let's talk about, so airflow in and out of the lungs is going to depend on a positive transpulmonary pressure. Transpulmonary pressure is equal to the difference between the intrapulmonary pressures, the pressures within the lungs that hold the airways open, minus the external or interthoracic pressures. These are the pressures that surround and compress on the lungs. So during a forced expiration, that transpulmonary pressure, the difference, is decreased, and it drops even further as air moves out of the lungs, and that can lead to compression of the airways. This can also occur during normal expiration in persons with lung disease. Anything that causes an increase in airways resistance can accentuate this even more. Things such as pursed-lipped breathing, grunting in infants, and a positive pressure ventilation, they help to increase the airway pressures, the pressures inside the lungs with expiration, and that's going to help to keep airways open. So a lot of patients with like emphysema may adopt this kind of pursed-lipped breathing when breathing out, and that's going to help to raise those pressures and help prevent the airways from collapsing and helping to reduce the airways resistance. Okay, so let's go through a scenario here. A man's lungs were damaged during a fire. He developed severe respiratory distress. The doctor said smoke inhalation had caused an inflammation of his alveoli. The damage had also destroyed some of his surfactant. So what effect do you think this would have on his lung compliance? What effect do you think this would have on his lung compliance? And then why was he given positive pressure ventilation? So let's think about it. So if we have less surfactant, then we're going to have an increase in our surface tension, and that's going to lead to a decrease in lung compliance. It's going to be much more difficult to inflate the lungs, and it's going to be difficult to keep those alveoli inflated. Now he would be given positive pressure ventilation to increase the pressure within the alveoli and help prevent those alveoli from collapsing with expiration. Okay, let's review some lung volumes and capacities. So our tidal volume here, this is just simply the volume of air that is exhaled with each breath. So a patient here is blowing the air out. So it's that difference. Normally at rest, this is about 500 milliliters. Our vital capacity is our total volume of exhaled air from a maximal inspiration to a maximal expiration. So here we start with our tidal volume. We take a big breath in, completely fill our lungs with air, hold it for a second, and then we blow all our air out as hard and as fast as we can, and we have a maximal expiration. Okay, that term is called our vital capacity. Now if we measure it in a force maneuver like which I was describing, we would call that our forced vital capacity, or FVC. Now even when you feel like you get all your air out of your lungs, there's still some air remaining, approximately 1,200 milliliters, and this is called our residual volume. So that is the volume of air remaining in the lungs after a full exhalation. And then our total lung capacity, this is going to be the sum of our vital capacity plus our residual volume. So this is the total amount of air that can be contained in the lungs at one time. Okay, let's look at that FVC and FEV1. Okay, so this graph shows volume over time. So we have a patient breathing normally, tidal volume here, takes a big breath in, completely fills their lungs up, holds it for a second there, and then blows it out as hard and as fast as he or she can until they can no longer blow out any more air and reach residual volume. Okay, so the first thing we're looking at here is the forced vital capacity. This is the maximal amount of air that can be rapidly and forcefully exhaled after the full inspiration. So we're going to measure the lowest point on the volume curve here to the highest point. Okay, so that difference is the forced vital capacity. Now the forced expiratory volume in 1 second, this is a measure essentially of the speed with which you can exhale. So we measure that from the point, the maximal point here. After just 1 second, we see how much air that patient can get out. And you can see in a normal healthy individual, most of the FVC is exhaled in that first second. Then we can look at the ratio of the FEV1 divided by the FVC. So that is the percentage of expired air expelled in the first second. And it's expressed as a percentage of the FVC. Okay, so let's look at what happens, what do we see with the FVC and the FEV1 in obstructive and restrictive disorders. Okay, so that ratio of the FEV1 to FVC can be used to help determine obstructive versus restrictive diseases. So normally that FEV1 to FVC ratio is around 80%, 85%. So let's see, if we have obstructive disorders, these disorders often have a high compliance with an increased airways resistance. So FEV1 is reduced due to obstruction of the air escaping the lungs, okay, particularly during that maximal exhalation. So that's just within 1 second, the speed is dramatically reduced. Now the FVC, the forced vital capacity, may also be low, okay, because the person has lung disease, but it's not going to be as affected as much as the FEV1. In other words, the speed of air outflow is more impacted with increased resistance. So what we'll find is if we take the ratio of FEV1 to FVC, that ratio will be less than 70%. When I worked at National Jewish, I saw a lot of patients with emphysema with really low FVCs and FEV1s. I, believe it or not, would see FVCs of 0.4 liters and FEV1s of 0.2 liters. So that would be a ratio of 50%. Okay, really low. I've seen much lower than that too. Okay, restrictive disorders. This is where we have a low compliance, but normal airways resistance. So here in these patients, they're going to have a low FVC because they're going to have a difficulty even inflating the lungs. They're going to start much lower on that curve because they can't get air full of lungs full of air. They can't get their lungs full of air. But the FEV1 will be low or normal. However, that ratio, the FEV1 to FVC ratio, is going to be significantly higher, right? Because these patients have a hard time getting air in, but they can exhale really forcefully. So some of these patients that I'd seen, like with pulmonary fibrosis, they would have an FVC, say, of 1 liter, and also an FEV1 of 1 liter. So their problem was just getting air in, but not getting it out. Okay. So normal FVC is going to be closer to 4 liters. It's going to be depending on their values are going to be dependent on your gender, your height, your age, and your race. But around 4 could be fairly average. Okay, let's talk about alveolar ventilation and dead space. Actually, before I talk about that, I wanted to pull up some normal values for FVC and FEV1, because I quickly just kind of said about 4 liters. You can see for women, 4 liters would be a little high, but it'd be a little low for men. And this is in large part based on height. A woman my size, since I'm very tall, you don't all know that, but I'm almost 6 feet, would be predicted to have a higher lung volume simply due to my height. Okay, but so for this shows men, FVC, and then the dashed one here is FEV1. Women, FVC, and women, FEV1. Okay. All right, let me go back to where we left off here. Okay, so first I need to define minute ventilation. So minute ventilation is simply just the amount of air moving in and out of your lungs per minute. So it is going to be equal to the frequency of breathing times the tidal volume, just the air moving in and out of your lungs. Dead space, this is air that goes into your lungs but doesn't actually participate in gas exchange. Now we have anatomical dead space. This is simply the air in the conducting airways, such as the air in the trachea, the bronchioles. Okay, essentially the air in every part of your lungs except for the alveoli. So that part of the airways does not participate in gas exchange, so we call that dead space. Alveolar dead space is alveoli that don't participate in gas exchange, and this occurs with pathology, okay, so with disease. Physiological dead space is the sum of anatomical and alveolar dead space. Okay, so then if we wanted to know what the alveolar ventilation was, so that is the gas that is actually getting to and participating in gas exchange. This would be equal to the frequency of breathing, okay, breaths per minute, times the tidal volume minus the dead space. So we subtract that dead space out. Okay. So let's take a look at the next slide. A lot of times people think hyperventilation is simply rapidly breathing in and out of your lungs. And I want to explain to you why you can actually be hyperventilating by breathing very slowly and deeply, and hypoventilating while breathing very rapidly and shallowly. Okay? And this all has to do with alveolar ventilation. So first let me just define really quick hyperventilation. Hyperventilation would be alveolar ventilation in excess of metabolic needs. Okay? So that would mean that we are blowing off more CO2, this is defined in terms of CO2, than we are generating through metabolism. That's hyperventilation. Hypoventilation would be when our alveolar ventilation was less than our metabolic needs. In other words, if we are producing more CO2 than we are blowing off. Let's look at how the rate and depth of breathing affects that. Okay, so patient A here, subject A, is breathing very shallowly. So the tidal volume is only 150 milliliters. Remember, normal was 500. They're breathing rapidly, though. They're breathing 40 breaths per minute. So if you look at just their minute ventilation, the air going in and out of their lungs, they're at 6,000 milliliters per minute. But if we want to figure out their dead space, then we need to, if we want to figure out their alveolar ventilation, then we need to consider the dead space. Now the average dead space in a normal healthy individual is just the dead space in the conducting airways, which is about 150 mils. So the dead space in this patient is about 150 times their frequency of breathing, or 6,000 mils per minute. Well, that was their minute ventilation. So their alveolar ventilation is 0. Okay, so none of that ventilation is actually reaching the gas exchange surface because they're not clearing the dead space. Okay, subject B, that's just kind of our normal tidal volume of 500 breaths per minute, about 12 breaths per minute, very average rate. We get, once again, 6,000 milliliters per minute for a minute ventilation. But our alveolar ventilation is going to be our minute ventilation minus our dead space ventilation. And that's going to give us 4,200 milliliters per minute. You can calculate this a little differently by just taking tidal volume minus dead space, so that's minus 150, times the frequency of breathing, instead of figuring out this dead space ventilation. Okay. Patient C has a tidal volume of 1,000 mils per breath, or liter per breath. They're breathing very slowly. They also have a minute ventilation of 6,000, but their breaths are so big that they are dramatically clearing the dead space. Okay. So if we calculate that out, 1,000 minus 150 times 6 breaths per minute, we find their alveolar ventilation is a little over 5 liters per minute. Okay, moving on. Let's talk about perfusion. So perfusion, pulmonary perfusion, describes the blood flow through the pulmonary capillaries. Here, deoxygenated blood passes through the lungs and becomes reoxygenated. Now remember, the pulmonary system is normally a low resistance, low pressure circulation. So blood flow within the lungs is affected more by gravity, with the base of the lungs receiving more blood than the apex of the lungs when upright. The most important regulator of blood flow within the lungs is going to be hypoxia, or hypoxia-induced pulmonary constriction. So let's look at that. And this is a mechanism to help match ventilation to perfusion. We obviously want the best oxygenation we can get. So if we have a region of the lungs that doesn't have as much airflow, that's going to lead to decreased oxygen, pressure of oxygen, and that hypoxia is going to cause vasoconstriction of pulmonary blood vessels. And that's going to lead to decreased blood flow to that area. So we get local perfusion is going to be decreased, so blood flow is decreased in order to match that decrease in airflow. And this allows diversion of blood flow to better ventilated portions of the lungs. We see another thing in the airways that is similar. So if we have decreased blood flow to a region of the lungs, this leads to decrease in the partial pressure of CO2 in the alveoli. In response to that, we're going to get bronchoconstriction, and this is going to lead to decreased airflow. This is a local ventilation response. This local ventilation is going to be decreased to match that local decrease in perfusion. So once again, together, these things act to divert blood flow and airflow away from local area of disease to healthy areas of lung in order to best match ventilation to perfusion. It is this hypoxic pulmonary vasoconstriction that accounts for the increased the high pulmonary vascular resistance in the fetal circulation. So remember, the fetal lungs don't get oxygen. The fetus gets oxygen from the placenta from the mother. So that low oxygen content in the lungs of the fetus causes widespread, in this case, hypoxic pulmonary vasoconstriction in the lungs. And that's what causes the pressures to be so much greater in the right side of the heart in the fetal circulation. And that's what causes the shunting of blood from the right side to the left side in the fetal circulation. Once that baby takes a breath of air in, that oxygenates the lungs, and then that reverses the hypoxic pulmonary vasoconstriction, and then the pressures in the lungs decreases until it's about 1/5 of that of the systemic circulation. But I digress there. Going back to our current topic, this matching to ventilation to perfusion is a good thing. However, if we were to have generalized hypoxia, so widespread hypoxia throughout the lungs, such as that can occur with lung disease or at high altitude, that can cause widespread generalized vasoconstriction, and that's going to lead to pulmonary hypertension and increased work of the heart and right heart failure. Okay, let's talk about this scenario. The child has inhaled a peanut, which is blocking her left primary bronchus. So how will the ventilation change in her two lungs? Okay, so obviously if the left primary bronchus going into the left lung is blocked, then there'll be much less ventilation in the left lung and more ventilation in the right lung. So how will the composition of air in her two lungs differ? Okay, so, well, the right lung, which has more airflow, will be higher in oxygen and lower in CO2. And the left lung, which has less new fresh air, will have lower oxygen and higher CO2. So in order to match perfusion to that ventilation, which lung should she send more blood to? Since we have increased ventilation in the right side, she should send more blood to the right side of the lungs. And how should her body alter perfusion of the lungs? She should send more blood or perfuse the right side more. Okay, now we're going to talk about diffusion. So diffusion refers to the movement of gases in the pulmonary capillaries that refers to the diffusion of gases across the alveolar capillary membrane. So gases are going to move down their partial pressure gradients from high concentration to low concentration. For oxygen, this is going to be moving from the alveolus that has a PO2 of roughly 100 millimeters of mercury to the pulmonary capillaries that has a PO2 of about 40. So that gradient for movement, partial pressure gradient, is about 60 millimeters of mercury. Carbon dioxide is going to move from the pulmonary capillaries, which has a PCO2 of about 46, to the alveolus that has a PCO2 of about 40. So the partial pressure gradient for carbon dioxide is about 6. Okay, so how quickly these gases diffuse across the alveolar capillary membrane is going to be determined by several factors which are described by Fick's law. So Fick's law of diffusion states that the rate or the speed of diffusion is directly related to the surface area, the diffusion constant, and the partial pressure gradient, but inversely related to the rate, to the thickness of the membrane. So let's discuss each of these things. Okay, so the surface area is simply the area available for gas exchange. So this is everywhere the alveoli comes in contact with the pulmonary capillaries. So the greater the surface area, the greater the rate of diffusion. If we were all trying to leave a building all at once, if we had more exits, greater surface area to exit, we'd be able to leave faster than if we had a small surface area, one exit. Surface area is normally very high in the lungs, thought to be about as big as a tennis court. But it can be decreased in disorders such as emphysema. So smoking causes a loss of pulmonary capillaries and alveolar walls, and this leads to less surface area, and this is going to slow the rate of diffusion. Okay, I'll skip number 2 for a minute. Okay, number 3, the partial pressure gradient. That's what we were just talking about. So that was the difference between the partial pressure of oxygen or carbon dioxide between the alveoli and the capillaries. Now, this factor is the only factor that determines the direction of gas movement, okay? Because the gases are always going to go from high to low concentration. So for oxygen, from the alveoli to the blood; for CO2, from the pulmonary blood to the alveoli. Now, the partial pressure of oxygen can be decreased if we go to altitude. So if we go to altitude, there's less oxygen content in the air. So we'll have a lower PO2 in the alveoli, and that will decrease that partial pressure gradient. This can also occur with lung disease. This factor can also be increased by giving a patient supplemental oxygen. So if they had, say, a slower rate of diffusion because of decreased surface area, we could give them supplemental oxygen to help increase the rate of diffusion. Okay, diffusion constant. This factor is dependent on the solubility of the gas in water. Essentially what we're going to point I'm trying to make here is that CO2 is about 20 times more soluble than oxygen. So if we had a diffusion impairment, so if somebody was impaired, say because of decreased surface area, we would find that oxygen is affected first, sooner than CO2. Okay, so even though the partial pressure gradient for oxygen is 10 times that than for CO2, because of this diffusion constant, CO2 being 20 times more soluble and thus having a greater diffusion constant, we find with diffusion impairment, oxygen levels go down before CO2 levels go up. Okay, and then finally, the rate of diffusion is inversely related to the thickness of the alveolar capillary membrane. So in other words, how far do those gases have to travel? This distance can be increased in pulmonary edema when we have fluid between the alveoli and the pulmonary capillaries, and pulmonary fibrosis where we have scarring and thickening fibrotic tissue that increases that distance. Okay. Next. Well, why does the rate of diffusion even matter? Do the gases have all day to diffuse? Think about that for a second. Okay. If you answered no, you'd be correct. The rate of diffusion is going to depend on the heart rate. Okay, remember, blood is not stagnant. Those red blood cells are being constantly circulated through the lungs. However, normally this looks at our PO2. Remember, in the alveoli, the normal is about 100 or 104, technically, over time spent in a capillary. So we can normally see at the start of a capillary, even before we're only about a quarter in, we can be 100% saturated. We have our full PO2. So the red blood cells have picked up all of the oxygen they're going to pick up. Okay, so that's normal. Now, if we had a diffusion impairment, this line, instead of looking like this, could look something like this. Sorry, I don't have tools to draw on my computer screen here. Just follow my mouse. It goes like this, and it takes to the end of the capillary before it reaches the maximum amount. So a question for you is, if you had a diffusion impairment, why might some people with lung disease desaturate while at rest, while walking when they are fine at rest? So when I used to work at National Jewish many years ago, one of the things we did with patients, pulmonary patients, is a 6-minute walk test to see if they had enough oxygen. And so these patients could be totally fine at rest, but as soon as they started walking, their saturations went down. And the answer to that question, why they might desaturate while walking when they're fine at rest, is because that increases their heart rate and their demand for oxygen. Okay, let's talk about oxygen transport in the blood. So something I was kind of alluding to was oxygen being bound to hemoglobin, and I was calling that saturation. So most oxygen in the blood binds to hemoglobin within the red blood cells. We see about 98.5% of the oxygen carried in the blood is carried bound to hemoglobin. Okay, so oxygen binds rapidly and reversibly to hemoglobin. So our normal saturation value, this is the percent of hemoglobin that is bound to oxygen, is about 95 to 97%. So about 95 to 97% of oxygen binding sites on hemoglobin are occupied by oxygen in arterial blood. Some is carried just as dissolved oxygen. Now remember, oxygen is not very soluble in water, so we have very little amount that's actually just carried as dissolved. So what happens as oxygen leaves the alveoli, it enters the capillary blood as the PO2, but it is rapidly taken up by the hemoglobin. Okay, and only about 1.5% is carried just directly dissolved in the blood. Okay, then we get to the tissues. Oxygen unbinds to hemoglobin. Then we have PO2 again, and binds, can go directly into the body cells. CO2 is a little bit different. The CO2 is carried 3 main ways. Dissolved carbon dioxide. I remember CO2 is more soluble, quite a bit more soluble than oxygen. We get about 7 to 10% of CO2 is carried just dissolved. Combined with hemoglobin, we get about 20%. CO2 binds to a different spot on hemoglobin than oxygen. It binds directly to amino acids of globin. And once again, 20% is carried this way. But most carbon dioxide is carried as a bicarbonate ion. These arrows, sorry, got shifted. But as we can see, if we take CO2 in, plus the water in the blood, yields carbonic acid, which dissociates into hydrogen ions and bicarbonate ions. So most CO2 is carried as bicarbonate ion. So remember, as we talked about in topic 2, when we exhale, so we're driving the reaction this way, you remove CO2 from your blood, and that's going to decrease the amount of carbonic acid, and that would act to raise blood pH. Let's review the control of breathing. So the respiratory control center in the medulla and the pons, and these areas of the brain contain pacemaker neurons that are involved in initiating inspiratory and expiratory movements and incorporating afferent impulses that come in to give information about lung stretch and so forth. And then that pacemaking essentially is regulated through various mechanisms. So we have lung and chest wall receptors. So we have stretch receptors that don't allow the lungs to be overstretched. In other words, like if the lungs are getting overstretched, they'll stimulate the control center to inhibit breathing. There's irritant receptors within the airways to inhibit breathing, such as, like I said, could be stimulated with hydrochloric acid, breathing in hydrochloric acid. Voluntary regulation of breathing, and that's through higher brain centers, so you can choose to hold your breath. You can only choose to hold your breath for so long, and then CO2 will build up so much that you will be forced to take a breath. There's various cough reflexes that are going to help to keep the airways clean. And then we have chemoreceptors, and these chemoreceptors are sensitive to high levels of CO2, low levels of oxygen or hypoxia, and pH. So let's look at some of these. So first of all, the receptors that detect this, we have central chemoreceptors that are found in the medulla, and they measure PCO2 and pH of the cerebral spinal fluid. So they're going to increase respiration when PCO2 increases or brain cerebral spinal fluid pH decreases. And then we have peripheral chemoreceptors that are found in the carotid arteries and the aortic arch. And these measure both PO2 of the arterial blood and the hydrogen ion concentration of the arterial blood. And these are going to, or the O2 is going to increase respiration when the PO2 is less than 60 millimeters of mercury. Okay, so let's look at those things. The hypercapnic drive, this is the control of breathing in response to CO2. And this is the most important controller of ventilation in a normal, healthy person. So on a breath-to-breath basis. So as blood levels of carbon dioxide increase, this is going to stimulate increased ventilation to blow off CO2. So if we look at this graph here, this shows minute ventilation over arterial PCO2, and you can see this curve is pretty steep. So small changes in CO2 are going to dramatically increase ventilation. I got to test this for myself when I worked at National Jewish doing a hypercapnic test on myself. Well, someone was doing it on me. So for this test, I started with 100% oxygen from a tank, and then I was rebreathing the same air. I had a pulse ox to measure my oxygen concentration. Now every time I blew out CO2, and that allowed the CO2 in the air that I was rebreathing to build up. Now since I started with 100% oxygen, and normal air is only 21% oxygen, my oxygen levels didn't decline. I had plenty of oxygen, but my blood levels of CO2 increased. And I could just feel myself just taking bigger and bigger breaths without even wanting to or trying to, I should say. It was just automatic, and that was in response to the hypercapnia. We also have a hypoxic drive, And once again, this is controlled by peripheral chemoreceptors. So they detect low levels of oxygen or hypoxemia in the blood. But these chemoreceptors are not very important over ventilation because normally PO2 is well above that value. So we can see our normal resting value of about 100, a PO2 of 100. And your PO2 has to drop below about 60 before we see a real increase in ventilation. So on a breath-to-breath basis, hypoxic drive in a normal healthy individual is not very important. However, if oxygen levels should drop below 60, you will have a very large response. This can be seen by the curve here. Now those peripheral chemoreceptors, they're also going to be sensitive to changes in pH, and that's going to be in response to metabolic acidosis or metabolic alkalosis. Changes in PCO2, remember, are going to be detected by the central chemoreceptors. Now, what's going to happen then to patients that have chronic hypercapnia? Okay, so these are patients like with COPD that have chronically high levels of CO2. Do they constantly just keep breathing deep and rapid in response to the CO2? So think about that for a minute. And then the second part of the question is, why is it important to carefully titrate oxygen levels in those patients? So think about that. Okay, hopefully you have thought about that and come up with some idea. And we'll look at that on the next slide here. So in patients who have chronic hypercapnia, over time those chemoreceptors become insensitive to the high PCO2 levels. Okay, so essentially you could say that chemoreceptors get reset to a higher level. So there's a new norm of CO2 for these patients. So instead, these patients have to rely on their hypoxic drive. Okay, and that's why it's going to be important not to give patients too much oxygen. Okay, because patients with chronic hypercapnia are going to rely on that hypoxic drive to stimulate breathing. So if you give the patient too much oxygen, they're going to lose their drive to breathe. So then if they lose their drive to breathe, what's going to happen to their CO2? Their CO2 is going to go even higher, and this is going to cause respiratory acidosis. This could be pretty severe. Okay, it could lead to severe respiratory acidosis, tiredness, lethargy, coma. Okay, concept check. Make sure to take a few minutes to look over the concept check questions and make sure you understand and can answer those questions. Okay, next we're going to be moving on to manifestations of respiratory disorders and respiratory tract infections. Actually, I take that back. The manifestations are actually not included in the slideshow, but you'll want to make sure that you're familiar with terms that are associated with, such as dyspnea, that are associated with respiratory disorders. So following your study guide, there's a list of terms, and you want to make sure that you're familiar with those. So we're going to instead move right on to respiratory tract infections. Now, we're not covering everyone in the book, but we're going to hit a few, and those are shown here. Okay, so let's start with some upper respiratory tract infections. Laryngotracheobronchitis, also known as croup. This condition is a really common viral infection found in children, usually 3 months to, on the high end, 5 years of age. It's usually caused by a virus such as parainfluenza, adenovirus, respiratory syncytial virus are the main culprits. The onset is gradual, usually follows some other cold symptoms. Results in inflammation of the mucosa of the larynx, and that's why it affects their sound. their voice sound. So it causes a hoarse barking cough and an inspiratory stridor. And this is worse typically at night. Symptoms can often be relieved by exposure to cold or mist air. Sometimes parents just walking out to the car to take their kid to the hospital. This will reverse. We've just taken our own son outside in the cold air, or if it's a warm summer night, open the freezer. The infection is usually self-limited, but if it's severe, it may require some treatment with steroids. I'm going to show you a video that describes this a little better.
Is this Justin? Where did he go? There you are. Hi, Justin. What happened to your voice? Is that what happened to your voice? When you breathe in, it goes. Is that what you do too? When did that start? This morning? You woke up? So you were fine yesterday? Yeah. So you know what's happening? You've got a little viral infection. There's different viruses that cause some swelling right here, and then it makes you hoarse. And it goes like that. Croup always gets worse at night. So in this situation, where you've got a significant stridor, that noise that you have, we're going to do a little bit of a steroid. Now, you can do an oral prednisolone, you can do oral decadron, the same one that's used to inject. You can also do oral. So what we're going to do today, you don't have to give as much. Prednisolone tastes horrible. There are things like Oropred, which comes in a dissolved tab, or a liquid, tastes a little better. Anyway, you have a classic case of croup. It is a viral thing. You do not need antibiotics for viruses, folks. You just need to add moisture to the air. So a humidifier can be hot or cold. And sometimes if it's really misty out, you can just go outside. Some people drive into the hospital with the window down in the mist and they get into the hospital. They're all better. But we're going to get some humidification going for you, a steroid to decrease the inflammation in the airway. And folks, that's the case of croup. Thanks for watching. Thanks for sharing with us today. Croup, by the way, tends to be this time of year, around Thanksgiving, Christmas time. Very good. Thank you.
Okay, next we have epiglottitis. This is an acute infection in children, ages around 2 to 7, usually caused by influenza type B. Rapid onset, and this results in epiglottis inflammation and swelling, which obstructs the airway. Patients are at risk for complete obstruction of the airway, which could lead to death. Signs include high fever. A child may sit in the tripod position in order to breathe better. Drooling because they're not swallowing, difficulty swallowing, and anxiety. I'm going to show you a video. This boy is pretty sick and trying to sleep.
This boy was admitted to the intensive care unit 3 hours previously. He has acute epiglottitis. He's sick-looking, toxic, and lethargic. He breathes at all times through a widely open mouth. Characteristically, at no stage does he swallow, and although it's not evident on the screen, saliva was seen pooling in his mouth. Listen to the low-pitched snoring, inspiratory and expiratory noise, contrasted to the higher-pitched stridor of croup. The posture of this child is difficult. He prefers to sit upright. As soon as his head drops forward, he wakes. Notice that coughing is absent, in contrast to the frequently heard barking cough of the previous children with croup. Each of the conditions illustrated is associated with...
The next one we're going to talk about is bronchiolitis. And this is acute infection seen usually in infants that are less than 2 years old. This is usually caused by the respiratory syncytial virus, or RSV. Onset is gradual. It's usually preceded by a stuffy nose and other signs. And ultimately, the virus leads to inflammation of the mucosa of the bronchioles, and that this obstructs those small air passages. Signs include wheezing and dyspnea, rapid and shallow respirations, cough, chest retractions, nasal flaring, a fever, and malaise. Okay, so that was bronchiolitis. Note that bronchiolitis is a lower respiratory tract infection, while the first two, croup and epiglottitis, involve upper airways. Okay, pneumonia. Pneumonia is classified based on the causative agent, how it's distributed throughout the lungs, and whether it's community or hospital acquired. For causative agent, typical pneumonia involves bacteria that multiply in the alveoli, leading to inflammation and the buildup of exudate. Atypical or interstitial pneumonia is usually caused by viral and mycoplasma infections, and these invade the alveolar septum and interstitium and leads to fluid buildup in the interstitium, but not in the alveoli. So distribution. Lobar pneumonia is where we have consolidation within a lobe or lobes. So it's completely fills an entire lobe or lobes. Bronchopneumonia involves scattered patches of pneumonia spread throughout the lungs. Okay, pneumonia can also be classified based on whether it is hospital-acquired or community-acquired. Hospital-acquired pneumonias are those that occur 48 hours or more after hospitalization, and most of these are due to bacterial infections that are picked up in the hospital. Community-acquired are infections occurring outside of the hospital, and these can be bacterial or viral infections. So acute bacterial typical pneumonia is a high cause of mortality in the elderly. Part of the problem is they lack a cough reflex and aspiration. They can aspirate, coupled with declining immune response. As they age, the immune system goes down. Those are important contributors to them getting and not recovering from bacterial pneumonia. It's typical pneumonia, it's bacterial pneumonia, so it's caused by bacteria, of course. Usually it's pneumococcus. Distribution, the infection is localized into one or more lobes. So we can see consolidation here in this lobe. It involves inflammation and vascular congestion, so we get fibrinous exudate that forms in the alveoli, and that forms that consolidated mass. The onset is sudden and acute with high fever and chills, fatigue, increased white blood cell count, dyspnea, rapid breathing, increased heart rate. And because the fluid buildup is in the alveoli, we get a productive cough and with kind of a rusty sputum, and that's due to the presence of red blood cells in the exudate. We get breath sounds rails to no breath sounds as it becomes worsened in the affected lobes. Primary atypical pneumonia, also called interstitial pneumonia. This is caused usually by mycoplasms. These are small bacteria without cell walls, or viruses such as influenza, RSV, and adenovirus. This type of pneumonia is more common in children and young adults. The distribution is interstitial inflammation, and this is around the alveoli instead of in the alveoli. The onset is variable, could be slow or rapid. Signs include a non-productive cough, and that's because there's no fluid in the alveoli, so you're not going to be coughing up stuff. There's a variable fever, headache. This infection can vary greatly between patients and severity, in part depending upon cause. And this infection is usually self-limiting. Okay, that's pneumonia. Tuberculosis. Tuberculosis is the world's foremost cause of death from a single infectious agent. And this is due to the Mycobacterium tuberculosis. This bacterium has kind of a protective capsule that allows it to stay alive for many years, kind of dormant. TB is transmitted by airborne oral droplets, like the person coughs, an infected person coughs, and another person inhales that. Contributing factors, close housing conditions or immunodeficiency. You don't have the immune system to fight it off. Malnutrition and alcoholism kind of fall into that too. Chronic disease, HIV infection are some causes or contributing factors. It affects other organs, but the lungs are most often involved. Okay, upon first exposure to tuberculosis, you can get a primary infection. So this is in people that are previously unexposed. The majority of patients, about 95%, that are exposed to TB will have an adequate cell-mediated immune response, and the bacterium will get walled off in a gun complex and will be develop latent TB. So they would test positive on a skin test due to the cell-mediated response. Their immune system has reacted, but they would be asymptomatic and they would not be contagious. But in about 5% of people, the cell-mediated immunity is inadequate and they will develop active TB. And here they would get fever, pleuritic pain, fatigue, weakness, and they would get the bacterium in their sputum, and then they could cough it out, so they're contagious. Secondary TB occurs either if you get reinfected again, or you have reactivation of a healed dormant lesion from a previous infection. And this reactivation can occur if your immune system declines for any reason. So these can lead to TB, active TB, where the bacteria produce and infect the lung. Okay, so then that leads to the fevers, night sweats, fatigability, weight loss, and the development of a productive and purulent or bacteria-filled cough. This next slide shows a Ghon complex. That's that healed lesion. This is where the cell-mediated immune response isolates the bacteria, but this complex is composed of not only the bacteria but macrophages and other immune cells. And we get the development of casus necrosis inside. And this can be detected on x-rays. Cavitation occurs when we have large areas of necrosis. And so large areas of destruction within the lungs. And then extrapulmonary, meaning that it spreads to other lungs, other organs. Okay, diagnostic tests. So first exposure or primary infection can be indicated by a positive TB test. To determine if you have active infection, you would use sputum tests and chest x-ray. So in people that have a latent infection or have had a vaccine against TB, they're always going to have a positive skin test. So then these people would follow up periodically, if you're working like in healthcare, with the chest x-ray. Treatment is a combination of drugs, antibacterial drugs, and it involves a long-term treatment of about 8 or 9 months. So there's some difficulties with compliance of patients. And over the years, there's been development of multi-drug resistant forms of TB. I used to work at National Jewish Hospital, and we would get these requisitions sometimes that would say MDR TB, multi-drug resistant tuberculosis. It always made me a little bit nervous. But OSHA always made sure we were well protected. Anyway, here's an old picture of National Jewish Hospital. So it started out as a TB sanatorium, and one of the things I thought was helpful was exposure to sunlight. So here's all these patients laying out on the roof in the sun at the corner of Colorado and Colfax. Okay, discussion. So someone in your class has a positive TB test. What does this mean? And are you at risk for infection? So think about that for a minute. So if you have a positive TB test, that means you have been exposed. You've had an immune response. But does that mean that you're at risk for an infection? If somebody else had that, are you at risk? So not if they have latent TB. If they have latent TB and they're asymptomatic and the bacterium is isolated, then it's not going to get in their sputum or their blood, and it's not going to infect you. All right, that's all for now. We'll see you for respiratory disorders part 2, which I may make a part 2 and part 3. We'll see, because it's a lot longer than this one. Talk to you later. Bye.